Gresham College presents Mad, Bad or Sad by Professor Glenn D. Wilson.
Thank you, Frank, and good evening, ladies and gentlemen. I'm going to be talking about personality disorders and some of the problems of diagnosis within the field of mental health and or illness. You probably recognize this is a scene from a film called Fatal Attraction, in which the character played by Michael Douglas is a happily married man who thinks he can get away with a one-night stand with the character played by Glenn Close. And it's a bit of a cautionary tale because, as you no doubt know, she doesn't go away quietly afterwards and completely wrecks his life. See if we can move forward like that. Yes, you have no doubt been up to speed with the news that a certain celebrity chef, whose name I won't mention, was caught shoplifting from his local Tesco's. Not just on one occasion, but apparently he had been doing it habitually. He cited overwork, stress, various aspects of an unhappy childhood, being sent to boarding school, being abused by relatives, but still claimed that he was a bit baffled by his own motivation and announced that he would immediately enter therapy. Now, was he a little bit mad, a little bit sad, a little bit bad, or maybe a bit of all three? What might have seemed a very simple issue at one stage in history has now become rather complicated. There are many psychologists who are concerned about the use of diagnostic systems to classify maladaptive behaviors as illnesses when they might be better understood as being on a continuum with normality. There's a tendency to be medicalizing behaviors that might just seem distressing or upsetting, either to the individuals concerned or to those about them. And to some extent, this may be encouraged by medical insurance companies and drug companies who have their own interests involved. Medical insurance payments in the United States very often depend upon a diagnosis being assigned, a medical-sounding label of some kind. Drug companies love diagnoses because once a behavior has been classified as an illness, then they are able to identify drugs that can be applied to it, and others will be developing surgical procedures to address them. Consider the rather phenomenal rise in the diagnosis and treatment of something called attention deficit hyperactivity disorder, ADHD, it's usually abbreviated as. As many as 1 in 5 American children are taking Ritalin, a stimulant that is intended to treat hyperactivity. Prescriptions in Britain have doubled in the last 5 years. Despite the fact that there is no satisfactory medical test for this condition, no clear way of deciding whether or not a child is suffering from it. And in fact, the behaviors for which it is prescribed sound rather typical of naughty, inattentive little boys, mostly, especially those who are on fast food diets, who lack exercise, who stay up late to watch TV or play video games, and whose mother smoked during pregnancy. Nobody's quite sure about the long-term effects of stimulants on the developing brain of a young boy, and there's concern about financial incentives in the form of disability allowances that may be paid to the parents of children who achieve this diagnosis of ADHD. Something similar seems to be happening in the case of women in depression. There are twice as many women as men that are diagnosed as depressed, and if one is to go by the prescription of antidepressant drugs like Prozac, the rates of depression seem to be soaring, again, particularly in women. Now, I've no doubt depression is a real condition, But what would account for this escalation? Is the lot of women really that much worse than it was previously, despite all the efforts of women's liberationists? That seems a little bit unlikely. And one has to wonder whether aggressive marketing on the part of drugs companies has something to do with this. Those of you who were around, like me, in the 1960s and 70s will recall that enormous numbers of women who went into their GPs complaining of anxiety or just difficulties in coping were prescribed tranquilizers, minor tranquilizers such as Valium. These went out of fashion when they were discovered to be addictive. And it appears that antidepressants have taken over as mother's little helper. They may turn out to be addictive as well. We're not quite sure. It's interesting that the NICE guidelines, the National Institute of Clinical Excellence, say that talk therapies, like cognitive behavior therapy, should be the first-line treatment. But these are rather difficult to arrange. They are in short supply. Many so-called sexual disorders would have been considered normal variations in the past. Now anything less than bedroom bliss is treated as a disease. Women who have orgasm difficulty or suffering from what is called hypoactive sexual desire, lack of interest in sex, and that's perhaps around half of the female population, are now recommended testosterone-enhancing drugs. And about a quarter of men suffer premature ejaculation at some time or another, particularly when young. They are now offered things as drastic as radiofrequency nerve ablation in order to reduce the strength of the pleasure signals that are conveyed from the genitals to the brain. It seems rather extreme, given that time might have the same effect, either boredom with the partner or aging of the individual. I'm sure it's a self-correcting problem. Sex addiction, what used to be called promiscuity or infidelity, is also recommended for the reverse, anti-testosterone therapy. And one of the things you have to be a little bit concerned about is who are some of these treatments intended for? Who are they supposed to benefit? The patient themselves, or perhaps their partner, somebody else who finds their behavior troublesome? The classification of mental disorders is a movable feast. The best known system is the American Psychiatric Association DSM-4, the Diagnostic and Statistical Manual, 4th edition it's in currently. It's under review at the moment, and drafts have been issued by the APA task force. We're expecting the final DSM-5 in 2013, next year. Various new conditions have been considered for inclusion. Here are some of the interesting ones. Absexuality is sometimes dubbed the Mary Whitehouse syndrome because it refers to the thrill of being appalled by salaciousness. You might recall that the anti-porn campaigner Mary Whitehouse was so upset by Kenneth Tynan's use of the F word on television that she wrote to the Queen saying that he should have his bottom spanked. Little realizing that he might possibly have enjoyed that. Other possible categories that have been suggested for inclusion include hebephilia, which is a sexual attraction to pubescent adolescents, young adolescents, just below the age of legality. There is one called sluggish cognitive tempo disorder, which you might better understand as laziness, negativistic personality disorder, which means whinging, nicotine use disorder, otherwise known as smoking, and intermittent explosive disorder, I think, is already in the list, actually. It just means adult tantrums. Well, maybe not all of these diagnostic categories will make the final list. Absexuality, I have to admit, has been put forward by one particular sexologist, a feminist called Carol Queen, so that may not gain the consensus necessary. But some of them will get there, and of course, the more diagnostic categories we have, the more business there is for therapists out there, and the more potential profit for the drug companies in producing cures for them. In fact, we may just be medicalizing eccentricity or just plain bad behavior. The sociologists are concerned about this. They say that we risk losing the distinction between people who are genuinely mentally ill and those that are showing normal stress responses to social conditions such as loss of status, resources, and attachment. Their concern, of course, is that if we diagnose it as a mental illness, then we go straight to drug treatments and so on, rather than considering improvements in social conditions that might be at the root cause of some of these distressing illnesses. A notable thing about these DSM categories is that they are agreed by committee and consensus, and of course they will evolve with time and with the cultural context. At a time when homosexuality was illegal in the UK, up until the 1960s, it was regarded as an illness. It had its own numerical code within the DSM. It was originally, in 1953, the first DSM, it was described as sociopathic personality disturbance, SPD. 1973, the DSM second revision, it was called sexual orientation disturbance, with the unfortunate acronym of SOD. In 1980, they dropped the idea that homosexuality in itself was a mental illness, but came in with the diagnosis of ego-dystonic homosexuality, meaning being homosexual and not wanting to be, not enjoying that condition. In 1987, that was dropped, EDH was dropped, but it crept back in under this rather vague heading, sexual disorder not otherwise specified. One of the examples being persistent marked distress about one's sexual orientation. Where's it going to go next? What's going to happen in the DSM-5? Nobody quite knows, but political correctness is getting so powerful that we might have a new condition that they describe as homophobia. It already sounds like a mental disease, doesn't it? So it's incredible that within a few decades we have gone from the point of throwing people into prison for homosexuality to threatening them with prison if they don't like the idea or pronounce against homosexuality. That seems to be the way we're going at the moment. Most clinicians, of course, don't regard homosexuality as an illness, but nevertheless, a recent study by Bartlett and company found that 17% of UK mental health professionals had treated clients for homosexuality in the past, and 4% said that they would continue to do so in the future, despite a lack of evidence that sex orientation can be altered by therapy and the possibility that it might actually do harm. Then there's the idea of sexual addiction, which, as I say, we used to call things like promiscuity and infidelity. It's likely to become hypersexuality in the DSM-5. It seems to be promoted by feminist demands that men stop philandering, which paradoxically, because it's a medical sounding name, is sometimes embraced by men who are seeking an excuse to deny responsibility for their bad behavior, perhaps with their arm twisted seriously up their back by an angry spouse. The message, of course, being, it's not my fault, I can't help myself, I am in the grip of an addiction and I need treatment. But, of course, evolutionary psychologists point out the fact that the pursuit of multiple partners is typical of men. It's something that is driven by testosterone. And so-called hypersexuality seems to be indistinguishable from high libido, any measure that you can take of sex drive. Of course, if your libido is excessive, it can get you into terrible trouble. It can destroy your marriage and your family stability. It can lead to charges of sexual harassment and rape, in which case some self-control therapy might be appropriate. But once again, I would say that the important thing is that the therapy be in the interests of the client, not others who might want them nobbled or restrained in some way or another. The issues surrounding psychiatric diagnosis are particularly salient with respect to personality disorders. Down the left is the current list of personality disorders in the DSM-4. They cluster into three groups. There is the odd eccentric group, which includes paranoid, schizoid, and schizotypal personality disorder. There is the dramatic, erratic cluster, which includes antisocial, borderline, histrionic, and narcissistic personality disorders. And then there is the anxious, fearful cluster, which includes avoidant, dependent, and obsessive-compulsive personality disorders. Down the other side are the personality disorders recognized by the ICD-10, which is an alternative classification of mental diseases favored in European countries. International classification of disorders, I guess that it is. And it's in its 10th revision at the moment. It's got a similar list of personality disorders, just a fewer of them. And obsessive-compulsive they are calling anancastic, for reasons that escape me, because it's not a word that is understood by most lay people. Probably that is its perceived advantage within medical circles. Now, there are obvious problems with the personality disorder categories as listed in the DSM and the ICD. They are determined by consensus or committee rather than any form of psychometric logic. Their reliability is poor in the sense that same patient given to several different diagnosticians, they'll come up with different labels for them, with particular overlap occurring within those three groups, so that, for example, borderline is likely to be confused with histrionic and narcissistic more often than borderline will be confused with anancastic. So there's a great deal of overlap, and what in medical terms they call comorbidity. That is, sometimes they will diagnose you as suffering from two of these personality disorders simultaneously. And the overlap is greater within the three clusters. Perhaps the biggest problem of all, as seen by academic psychologists particularly, is that these categories are on-off categories. The clinician has to say yay or nay. This person either has the disorder or they don't. When in the real world, we know that there tends to be a continuity between people who are 100% normal and those who are extremely potty. Most people are somewhere on a continuum between the two. And the DSM categories do not, at the moment, recognize that. Another problem, from the point of view of research psychologists, is that the diagnostic category incorporates certain exclusions which amount to making guesses about the etiology of the disorder while you are in the process of labeling it. So that, for example, you do not call something a personality disorder if it has been induced by stress, or by brain damage, or by drugs, or if the condition is better described as neurosis or psychosis. There are a whole lot of other categories that you put people in if you decide that they are neurotic or psychotic. Personality disorders have to be separate from and exclude all of those. So it's a monumental job attaching these labels, and it involves you in second-guessing how they might have originated before determining the label that you put on them. And the final problem may also be very important, is that the labels can be used as a jargon for insulting other people that you don't like or don't like their behavior. And more than that, it can be stigmatizing. It can affect their future or other decisions that are made about them. I was, some time ago, asked by a solicitor to look at a lady who was a rape complainant. They were acting for the guy who had been accused of rape. And their hope was that I could classify her as personality disordered so that doubts could be raised regarding the credibility of her testimony. And in fact, she did exhibit many erratic and theatrical behaviors that you could describe as histrionic. She was a recreational drug user. She'd smoked cannabis on the night in question, together with the alleged assailant, who incidentally was an ex-boyfriend. She had a track record of lying about her sexual activities and throwing a tantrum when the lie was exposed. On the particular night in question, she had invited the defendant to her